So I'm really passionate about partial knee replacement. Trained in it starting in residency and then again in fellowship and then further in my career. I do probably more partials than I do totals. So that's my bias. If I have a bias towards partials because you'll see why in this talk. So we have to really think about the knee in 3 different compartments. So it's the patellofemoral joint, it's the lateral joint, and it's the medial joint. And so when you break it down that way and you look at x-rays critically, thinking about these different joints, you can start to see very specific reasons why or why not to replace one joint at a time or one part of the joint at a time versus the entire joint. So commonly, we probably have some radiologists here, we just see on the x-ray tricompartmental arthritis. That is a catch basin for so wide of a spectrum of arthritis. It's shocking. Like clearly the one on the right, you would expect that is global tricompartmental arthritis. That needs a total knee. Even the second one, pretty bad. You still see some space laterally. There's an ACL reconstruction that was done, but that's still really bad. That probably needs a total knee. Then you start getting to x-rays like this, just the medial side, or this x-ray where now it's just there's space in the main joint, but the patellofemoral joint is bone on bone. So I would suggest when looking, I like to look at my own x-rays and look at my own MRIs because tricompartmental arthritis may not in fact be tricompartmental arthritis. And of course we're orthopedic surgeons, so what do? Everything is a total knee replacement and just slamming total knees in, right? All the time, total knee, total knee, total knee. But we're trying to be a little more delicate, a little more finesse to our diagnoses. So 10% of people with total knee replacements are dissatisfied. That's not good enough. That's a lot of people. There's a lot of total knees that go in. And so what are the reasons? And that's one of the next frontiers of orthopedics is how do we get these dissatisfied patients into the satisfied group? I would say, from having seen a lot of different follow-ups, sometimes putting a total knee in a patient with isolated medial arthritis is a dissatisfier. It doesn't feel as good as a normal knee. It doesn't feel right to them, even though, yeah, their pain's better, but there's some more to it than just putting in a total knee. Poor technique, not getting the knee perfectly balanced is a huge part of it. It's very complicated. I mean, a total knee replacement, balancing an extension, flexion, mid-flexion, an A to P, medial to lateral, I mean, the degrees of freedom are extreme. And so to get that perfect is challenging at some level. And then of other things that can play into it. But again, I would say maybe some of the first 2 might be the 2 most important factors. And we can't just blame it on our physical therapists all the time. All right, and so just okay is not okay. And so I like to think of what is the best thing. Everything's not just a total knee. What is something we can be a little more finesse with? Now, why, I hear all the time, every day in clinic, well, everyone says I'm just gonna need a total knee anyway, so why don't I just do a total knee? Not true, If you look, let's see the laser right here. If you look at the survivor dataship, one of the longest survivor dataship that we have is with the mobile bearing partial knee. 85% are intact at 30 years, and this was one of the phase 2 of the Oxford partial knee replacement. And then, it goes down over time, but it's pretty good odds. It's pretty good odds at this point. However, if you compared it to total knees and partial knees, again, the difference, at 25 years, 70% survivorship on this forest plot versus 80%. And what's the problem? If a total knee hurts, what are you going to do? So a lot of this data, yeah, it might be higher, but what are you going to do if a total knee hurts? That's even more of a modern day mystery and black box to try to fix a painful total knee to another total knee. That's a very challenging world. So what does it look like on x-ray? That's just a nice x-ray of what a mobile spacer looks like. There's this little radio opaque line where the spacer is, and this actually moves and it mimics, it's called a meniscal bearing. It mimics the movement of the natural meniscus and has some sliding effect to it. So why partial knee replacement? Well, you keep all the ligaments. So in an ACL, again, to add to the complexity of a total knee, you cut the ACL. They've tried to not cut it. There's been different types of total knees trying not to cut it, but in the end, for going forward, the ACL gets cut in every total knee. And then PCL sometimes gets cut, sometimes doesn't. In a partial knee, we keep every ligament. So you keep all the ligaments in your knee. There's more likely some more natural biomechanics by doing that. And then you don't have to get into the quadriceps mechanism at all when you do a partial knee. It's called a mid-vastus split. And then there's less pain, less narcotics. It just makes sense. You're just not cutting out as much. You're not bleeding as much. There's not as much surface area for bleeding. And so for all these reasons, you get faster mobility, range of motion, return to activity, and work faster. But we would never say, well, this will be faster recovery for a long-term loss. And so we have to be very, very specific in who we choose for this procedure. Now, this is just a classic case. Again, Rosenberg up in Park City figured out that if you take a PA flexion view, it will sometimes accentuate the arthritis. So you can look like almost normal in an regular AP, but if you don't do a Rosenberg flexion view, you won't see that they go actually to bone on bone in that flexion view. That's almost the perfect patient for a partial knee because they're not bone on bone in both particulars. They have bone on bone pain, but when they're standing straight, it may not be engaging those two areas of bipolar loss. And probably because in a way it's so isolated, everything else is going to look really good. And sometimes we have to get MRIs to determine that, but this is a perfect case for a partial knee where it's only bone on bone in the PA flexion view and everything else looks good. Just a comment on robotic partials. So we're getting to more robotics, and the reason why is because of this grafter right here. They found pretty quickly in total hip replacement. I mean, wouldn't you want your scatter plot to be nice and tight and within bounds? The robotics helps us keep those outliers away, and so that everything gets really tight. We're hoping, and the data is still coming out, will a tighter scatter plot lead to better outcomes? That's the big, big question. But intrinsically, it makes a lot of sense. Let's hit our target that we're shooting for. And that is a fixed bearing robotic. So you can also replace the lateral compartment. This is probably one of the hardest cases I do. It looks so easy because there it is, right there. Well, you're going through the lateral retinaculum. That is extremely tight. It's extremely challenging. I dread it probably every time we have one on, but because everything else is so good, I've had some of my happiest patients with a pure lateral replacement because you keep what's good. Again, my background being where I am a sports medicine physician who does joint replacements, I'm really striving to be a minimalist and keep as much of their natural tissue and ligaments as possible. And then a patellofemoral replacement. So these are even more kind of challenging in terms of when to pull the trigger on a patellofemoral. In this patient, again, a lot of them end up being very young, 30 to 50 years old with isolated patellofemoral arthritis. And sure, there's some bone spurs in this person. They had an ACL reconstruction. But if you look really carefully at the cartilage and the meniscus, they have lots of good cartilage. Do we want to cut out all of that good cartilage when they're 35 and put a total knee in, knowing going from a total knee to another total knee someday is way more challenging than going from a partial to a total? So my minimalist and kind of philosophy is if you could get 15 to 20 years out of a partial and then get a total, that really kind of sequentially buys you a lot more time and not dealing with the complications and challenges of a total to another total. And that's what a patellofemoral looks like. So again, well-maintained joint space. And again, these patients, harder to really choose who needs a patellofemoral replacement as it can be a black box of its own. All right, and then finally, ex-NFL football players all come in, they've all retired, and they're 40 and their knees are trash. And so this guy, it's narrow, maybe not quite, bones aren't touching, but he bends down, still not touching. But when you look at an MRI, and even here, a lot of these NFL players get these lateral fascitectomies. So look, they just take off this little edge, and it just keeps them going, right? They just need to maximize their time while they're in the NFL, whether it's just 2 or 3 more years. And so they do everything they can to just keep them going. But when you do this, you know there's going to be damage to the entire patella surface. So here's the MRI, and it's just eroded. Yeah, sure, his meniscus is hanging on by a thread, but his ACL is perfect. This is his medial compartment, huge bone spurs, impinging osteophytes, and then just very thinning and just eroded patellofemoral space. So this is what it looks like in real life. Clearly that hurts, but again, a young guy, 40s, we want to just try to get 20 years out of something before maybe he actually needs a total knee. So you can, in some instances, do actually a bifem, where you replace the medial, you replace the patellofemoral, but again, keep all of the ligaments. This is a really rare case. Again, I'm even more critical in deciding when to do these, but someone who's very athletic, They want to, and they have really good soft tissue structures. We're going to try to do everything we can to keep those. And that's what it's going to look like on x-ray. So why do I prefer the partial knee? I think you get more normal kinematics because you're keeping all the ligaments. Definitely less pain, quicker recovery. Again, don't want to sacrifice long-term for just a short-term gain, but we don't disrupt the quad. So they're walking faster, less pain, less atrophy of the muscles. Decreased blood loss, quicker surgery, less narcotic use. I mean, there's so many wins. Again, but we don't want to lose the long game, but maybe this is a bridging for 15 or 20 years. But I can't emphasize enough, patient selection, patient selection, patient selection, technique, technique, technique. Doing mobile bearing knees, the data is clear. If you are a higher volume mobile bearing surgeon, your outcomes are better. It's tricky. You have a spacer that's moving and it can dislodge. It's very uncommon, but you got to get it right. And so if you get these things right and do high volume, you can usually get really good, again, happiest patients with these partial knees. They would love it. The best, and again, it's kind of it's almost like a cheat code. If someone had a total knee when they probably could have had a partial on the other knee and they come in, they have the same problem, and you do a partial, they act like that was the easiest thing, a walk in the park. If you do a partial first and then they need a total on the other side, they're always like, is something wrong with this? Because it always hurts a lot more. So it goes both ways, but anyway, I love doing partial knees for that reason. Got to choose the right patient. That's it.